it's so much more effective if you can understand the qualitative outcomes. What makes a difference to people?
And nobody wants to be sick and say, I'd love to remain sick. Nobody comes.
You know, if pain is untreated, it doesn't magically end because childhood does.
It's, again, a failure of the system to not have designed that to manage chronic disease.
When 3/4 of people can't actually afford the care that they need.
We need to understand it, we need to bring it out of shadows.
We wait, you're guaranteed for chronicity, right?
Because every time that we miss that opportunity for early intervention, pain just becomes more complex and more difficult to treat.
As an invisible illness in many cases, chronic pain does have a stigma. And
Chronic pain, it's not just a physical challenge, it's actually a mental health crisis.
Welcome everyone. It's my privilege as Chair of Chronic Pain Australia to be opening National Pain Week and also launching the 12th edition of the National Pain Report. It's wonderful to see so many familiar faces, leading researchers who are looking at innovations to address the chronic pain problem, clinicians on the coalface, and of course our community of lived experience. Also our industry partners who are here with us today, who give us dedicated support and believe in our mission and vision to address chronic pain in Australia. I wanted to make a special thank you to our lead sponsor, Haleon. For the past 3 years, Haleon has partnered with Chronic Pain Australia and National Pain Week, helping us amplify the voices of lived experience. I'd particularly like to acknowledge Jenny Walters and Jennifer Collins, and particularly all of the Haleon team. Many Australians know Haleon through trusted brands like Voltaren, Advil and Panadol, but today I'd like to thank the people behind those brands who stand beside us for our community in true partnership. I'd also like to thank Vold as well for using this really funky space. I think it's very cool and very envious of the workplace that they have. And if Chronic Pain Australia has a heart, that heart would be our General Manager, Kelly. Kelly is the driving force behind National Pain Week. She leads with compassion, determination, and an unwavering belief that every person living with chronic pain deserves to be seen, heard, and valued. Kelly does so many things for our organisation and has achieved so many different achievements for our organisation. We're a small but powerful organisation. And it's a reflection of her extraordinary leadership. And I'm so proud of you, and so is the rest of the board. So thank you very much. Pain lives here. It's a simple message, but a powerful one. Pain lives in our homes, it lives in our communities, it lives in our schools, our workplaces. Sadly for many, it lives in our children, it lives in our partners, our family, and our friends. Around 5.4 million Australians, that's adults and children, live with chronic pain today. Yet despite its scale, chronic pain is one of the most unrecognised conditions in our healthcare system. Unlike cancer, diabetes, or cardiovascular disease, chronic pain is not counted in our healthcare system, which means we're completely invisible. And that means we can't properly understand the issue, the depth of what pain is doing to people's lives, and how to service those people as best as we can. This is what we call Australia's national pain gap. And for the past 12 years, the National Pain Report is the only data source that we have on people's lived experience of chronic pain in Australia. And that's led by a community organisation, not AIHW or the government, but a community organisation. We launched the National Pain Report 2026. More than 6,000 respondents shared their experiences in this year's edition. Every response is someone's story. Every statistic represents a life. And what they told us should concern us deeply. 42% told us that they had to leave the workforce because of their chronic pain condition. Nearly 3/4 couldn't afford the care that they need, And about half of the people who responded to the National Pain Report cited $1,000 as the average household income, which is below the national poverty levels. 4 in 10 waited more than 3 years for a diagnosis, which is truly unacceptable. But perhaps the finding that stayed with me the most was that more than 1 in 3 respondents developed chronic pain before the age of 25. Those whose pain began young were almost twice as likely to wait more than 3 years for a diagnosis. They were more likely to experience poorer mental health, financial distress, unemployment, and feeling dismissed by healthcare professionals. One young respondent wrote, "I don't remember living pain-free and I'm only 25. It dictates every part of what I do and how I live." That one sentence says more than any statistic ever could. When recognition comes too late, the consequences shape the course of an entire life. That is the cost of not counting chronic pain. And that is exactly why today we are launching a petition, Make Pain Count. Australia counts cancer, we count diabetes, we count cardiovascular disease, and it's time that Australia started to count chronic pain. Today we are asking every Australian to stand with us by signing the Make Pain Count petition and calling the government to recognise chronic pain within Australia's national health data systems. Pain lives here, and it's time Australia counted it. Thank you very much.
Thanks, Nicolette, and thanks so much to the work of the organisation in collecting this data and giving us the opportunity to reflect on the evidence that we hear from the voices of 6,000 members of the Australian community living with chronic pain. I think now we've got an opportunity to explore a little bit more about the experiences of these people and the community broadly, and where Australia can go from here. And I think what we've heard from Nicolette is, the next part of the story is getting some national data sets and some national opportunities to count pain so that it's not just a symptom, it's recognising the people and their experiences. So we've got a great panel with us today, so I'm going to call them up and do a little bit of an introduction as we bring them up to the hot seats, as we're going to call them, because I'm going to give them some questions so that we can investigate a little bit more about this really important situation. So our first panellist is Kevin James. So welcome, Kevin. Kevin comes to us as a lived experience advocate who has generously shared his journey with chronic pain to help improve understanding, reduce stigma, and advocate for better care. Kevin brings the consumer perspective to today's discussions and reminds us of the human stories behind the data. And as Nicolette pointed to, every single piece of data there is somebody's experience. Our next panel member is Tanya Morris, Dr. Tanya Morris. We're very pleased to have Tanya with us, a senior specialist in pain medicine, co-director of the Sunshine Coast Persistent Pain Management Service, and board director of the Faculty of Pain Medicine Australia and New Zealand College of Anaesthetists. Tanya brings extensive experience with multidisciplinary pain care and is a strong advocate for improving evidence for the treatment for people with chronic pain. So thanks for coming today, Tanya. Our next panellist is Jennifer Collins. So welcome, Jennifer, who's the head of pain at Halion Australia. Jennifer brings more than 25 years of experience across consumer healthcare and is passionate about improving everyday health outcomes through education, partnerships and consumer-centred innovation. She's a strong advocate for listening to lived experience and believes the industry has a really important role to play in supporting better outcomes in pain care. Our next panellist is Joyce McSwan, a pharmacist by background, Chief Executive Officer of Open Pain Education Network and Director of PainWise. Joyce has spent many years advocating for pain education and supporting multidisciplinary models of care, particularly in the primary care environment, to improve outcomes for people living with persistent pain. Our next panellist is Dr. Karen Plummer. So welcome, Karen. who comes to us as chair of the Australian Pain Society Paediatric Pain Specialist Interest Group. Karen is a paediatric nurse and clinical scientist with a particular focus on pain in children and young people. And from what we've heard of some of the results, there's some tricky questions coming for you today. And is really interested in working on early recognition and assessment of management of pain across the lifespan. And our last panel member, but not least Louise, first here, last to the chair, is Louise Hardy, who's Chief Executive Officer of Arthritis Australia. And Louise is a respected health sector leader with outstanding record of achievement in health policy strategy and advocacy. So we're going to lean on you, Louise. We obviously need to get in the ear of some politicians. She has dedicated her career to improving outcomes of people living with arthritis, musculoskeletal conditions and chronic pain, championing the consumer-centred approach to research and health system reform. So quite the panel. We've got some questions that we're going to ask them and get some of their thoughts. But I wanted to lead off with you, Kevin, if that's okay. Looking at the report, I was quite taken with some of the things that Nicolette raised, particularly that 2/3 of people felt that they'd been sort of ignored and dismissed when they were seeking access to healthcare. And also, I think for me, the future impacts, particularly on those lack of access, delays to diagnosis and disengagement with the health system that could have on work and engagement in broader social activities and connections with community. And I think the report reminds us that every statistic is a person. So what resonated most with you from the report, and what do you think that Australia could do better about understanding what living with chronic pain is like?
Thank you very much for the question. Am I coming through clearly? Excellent.
Yep.
There's a lot to unpack there. Thank you for the question again. And what I would say is that there are a lot of barriers that chronic pain patients face, and I've kind of boiled it down into three main areas, what I call the 3 A's. A lot of chronic pain patients have difficulty with access. As we've mentioned, there are terrible delays, long delays quite often when you're seeking care, especially when you need surgery and you may be going through the public health system. It takes sometimes a couple of years. Personally, I had to see a psychologist a few years ago, and I rang up and tried to get an appointment or a referral, and they said if you're going through the public system, it will take about 18 months for you to see a psychologist. And I said, that's not good enough. What about private? I ended up going privately, and an appointment, I had to do 6 or 7, was $220, of which the government covered less than 50%. Now, I don't know who can afford that. And that's the second A, affordability. Not everybody can afford the healthcare. It's all well and good to say, in theory, yes, we have this, yes, we have holistic care, yes, we're here to look after you, you just need to come and see us. But a lot of people are socially isolated, a lot of people are lonely, a lot of people just don't have the money to go and see these specialists, whether it's public or private. There is also pharmaceutical expenses, and I know personally a lot of people who are on a disability pension. I'm also on a Centrelink payment. My wife is on an aged care pension. We're not on a huge amount of income, and sometimes decisions have to be made whether you're paying the rent, the food, or getting your new pharmaceutical prescriptions made up. Affordability is a big deal. That needs to be addressed. And most of us know if we have an enhanced primary care plan, we get up to, I believe it's 5 visits a year with the doctor or allied health, and you can get up to 10 in certain situations. But if you're seeing a physiotherapist, as I did a number of years ago, those 6 or 10 weeks are used up in a couple of months. What do you do for the rest of the year? Affordability is huge, as well as the access and the waiting times. The third A I want to talk about, and it's very important to chronic pain patients to be heard, to be listened to, and that is what I call agency. sometimes there's a big power dynamic in the relationship between the GP and the patient, or the specialist and the patient. And I'm not going to go into my situation, which occurred 17 years ago, or I'd be talking for an hour. But agency means to me that the patient and the doctor relationship needs to be shared. It needs to be a 50-50 responsibility. I'm very blessed. I'm on my 6th GP currently, and he's marvellous, and we have an open conversation. He understands, as a chronic pain patient, that I have the knowledge to have the discussion with him. After all, I'm a retired registered nurse, and that's what I do best. I research. And we have an open, forthright discussion about what painkillers I can use, what other things I've tried in the past as part of my holistic care plan. And at the end of the day, he makes the decision, but we discuss it as equals. And I'd like to see that happen a lot more with regard to the chronic pain patient's point of view. The whole thing needs to be a team. The team is working for you, and you need to be part of that team and advocate for yourself. So the 4th A I'm going to talk about is advocacy, and there needs to be a lot more advocacy, as well as by professionals and also those of us with lived experience. We need to step up, educate ourselves, but we need to be taken seriously, and we need to have a position on the board. We need to have a position in the discussion. We need to be part of the discussion. We need to make decisions on that. And I'm very pleased to report, to summarise and finish up, that I'm been able to participate myself in a number of consumer advisory committees in recent time involved with research. A lot of universities these days don't get their funding unless they have somebody with lived experience on the panel. And I'm very happy to put my hand up for that, and I've done this a few times, and it's very rewarding, and it's also very necessary for people with lived experience to participate in research for people with chronic pain, because often there's nobody on that panel or that research environment who has lived experience. So I'll just finish with that. The 4 A's are access, affordability, agency, but we need to advocate better for everybody. Thank you.
Fantastic. Maybe we should just wrap it up there. No, I think, Kevin, that's a fantastic message, and I think the coming from a university research background, you're kind of talking about the stick-shaped carrot of universities being sort of strongly encouraged/driven to include lived experience and consumer-focused research, but there is no doubt that that is the direction that research should be following, and we're going to unpack that a little bit further as we go down the pathway with the questions. But I think being able to have consumers, and I think to the advocacy point, who want to be involved in research and can provide that input, having done some of that in our own research, it adds a completely amazing factor to the quality of the research and the application of the research. So, universities might feel that is putting a burden on the research to have to include that in their applications, but it is absolutely the way that research has to go. You touched on access and having to wait and long lists for multidisciplinary pain clinics or access to multidisciplinary care team members. Tanya, I'm going to lean on you as somebody who's involved in a MDT service and MDT care. 40% of respondents said that they waited more than 3 years for a diagnosis, and more than half said that they'd never been referred to a pain specialist or a multidisciplinary care team. Why do you think we're still seeing those kind of responses in the survey itself? And what do you think we need to change to try and get in the next surveys that we see, a shift in the dial around those outcomes?
Thanks, Lisa, and thanks, Kevin. It was very helpful to hear that. I think chronic pain is extremely complex, and when a person presents with chronic pain to specialists or the GP, it's very difficult to work through what the priorities are. Because of that complexity, it's very challenging to get certainty around a diagnosis. It can take a long time because there's many different specialties then that the person is referred to get that clarification. Having said that, though, it's difficult also to find health professionals that will advocate for the patient and create that agency and collaborate about what they need next. So the complexity of the diagnosis, for one, because it ends up, there's lots of different, we saw in the report, there's lots of different reasons for pain that's being generated. It also can coexist with lots of different medical problems and complexity of medication management as well. So the healthcare sector is challenged by collaborating and being an integrated force to be able to look after a patient holistically and approach it in the most valuable way to the patient. But I think that then creates the delays in understanding that it's chronic pain. There's also the practical aspects that you highlighted, Kevin, as well, about affordability, the cost, and there's also geography and the sort of rural and remote. Persons with pain find it very difficult to access healthcare to start with and then being referred on to specialists. And I think one of the most important things that we can do about this is to utilise the most recent development of education standards, so the Australian standard for health practitioners and pain management education, to be able to have a standard and a level that's expected of the healthcare sector to understand and then be able to recognise, be able to assess really well, to collaborate with the patient, to compassionately communicate about that and appropriately refer on, and coordinate and integrated care in a holistic way. Because we just don't do the best thing for patients when it's fragmented. So that raising the level of the education and understanding and empowering clinicians to be more collaborative and step out of their lane more often, I think will help a long way to supporting chronic pain patients far better.
I'm going to come back to you with another question, but in the meantime, I might just nip to Joyce, if that's okay. It's all right, I'm going to come back to you, Jen. Joyce, you've done quite a bit of work in your clinical life and practice experience in partnerships between, say, the HHS and primary care, and looking at how, to sort of talk to some of the points that Tanya raised about the shared care models, how you might be able to work with primary care and the hospital and health services to optimise some of the ways that you can support patients to have a care partnership, and I think to address some of Kevin's issues around the enhanced primary care package, that you might only get 5 visits or 10 visits, how you can do those kind of things. One of the strongest messages from the pain report is that too many people are waiting too long to get the right care, and that we know that specialist services alone can't really meet that demand. So where do you think primary care needs to help people get this evidence-based treatment closer to home? Because going into the acute care facilities is not necessarily going to answer that question. We hear about ED departments full because beds are full, because ramping, all these other things. You can't kind of keep bringing people in. How do we get the right care at the right place with the people that have a relationship with people? How do we do that, Joyce? Go.
How long have you got? Look, this is a loaded question, and it's one I have spent almost 20 years of my life looking at with great lengths, and have had the privilege of designing programs, testing them within the primary care setting, which is a super unique setting, but that is where we all live as well in community. And it is without doubt We've tested different varieties, published on a few, and still testing some integrated models with the health system as well, and funding models as well, right? Mm-hmm. So people do best when things are accessible and close to home. There's without doubt. It is also by far more cost effective if you're talking about the spend for government when it comes to spending on healthcare. It really is most affordable for the government and the country, we all pay our taxes, to be there giving the care at that point. So primary care is while it's a common sense place of going, well, why isn't it there? The systems are not set up for that. We have a very archaic system that relies a lot on tertiary centres. And that's number one, a problem for access. When dominantly they are expected to look after what should remain in community care, doesn't. So that's one failure that has to be fixed. And without data, it's very hard to prove the point that, hey, we got a problem here, Houston, you know. So that's, I think, number one. And so the other thing with primary care, which is super unique, while it's accessible, is that practitioners have to have a whole myriad of things they've got to be very good at. Everything from skin health right through to flu, right through to chronic disease management. And more, unfortunately, again, through that pathway, not only is there a system to get in there, enhanced primary care services are only 5. So it's a big ask when science now tells us multimodal care is evidence-based. So as much as your health practitioner wants to work within that model, everyone's got to eat, everyone's got to get paid. So it's, again, a failure of the system to not have designed that to manage chronic disease, remembering that it's actually more cost-effective to do it at the point of care. The delay in access of that is what you're seeing in statistics, or the queue up, or the 3-year wait. So the delay of that means that we get chronicity. 1 in 5 acute cases become, 1 in 2, acute pain experiences become chronic. We wait, you're guaranteed for chronicity, right? And the definition of chronic pain is 6 months or more. So I think, you know, you don't have to be a genius to work out that that's why we've got such significant statistic. The other wonderful thing that Dr. Morris brought up, which is critical, is the education in our health system for medical school, for pharmacists. Even myself, when I went through pharmacy school, does not cover chronic pain well. And so the wonderful health standards of education and pain management that's come through means that we need to lift those standards. Now, a lot of us are now post-grads, right? Post. What we were taught now has to be translated here. And this is also why I am so fond of the social enterprise Open, which is the online pain education network, because that, without community helping, philanthropy helping to aid the problem, we can't lift the education of the ones who are currently practicing as well. So there's a lot of prongs, I think, that from systems error to cost, but by far, at the end of the day, if all of that was invested in, and it takes investment, we will save money, guaranteed. So it's been there, we have done the test, we have promoted it to government, they need to look at that cost sheet, and people are more fulfilled, they're back to work, lives are more productive, and nobody wants to be sick and say, I'd love to remain sick. Nobody comes. And so this is why, as an investment to government, for government to make, this is a capital cost issue that we can solve. We can solve this.
Just heading back to Tanya then from that. Sorry to ping pong over you, Jen. I will come to you. That's my problem from seeding you wrong. So hearing from Joyce, there's funding conundrums. We need to be able to support MDTs in community to provide better services. We need to retrofit and prospectively fit education into the system so that providers are better tasked to do that. We have to, hearing you, juggle priorities of the fact that people had 2 or more long-term health conditions that they were also juggling in the 6-minute medicine bucket. If we can fix those things, just saying, if we could, would a stronger, just being pragmatic, would a stronger primary care system help you? Would it help you? Because the bucket is never empty in health. The bucket is never empty. So would it help you in your specialist services to have those kind of systems in place? Could you set up different systems for your specialist services with a primary care that was functioning in the way that, in her rainbow kitten unicorn world, described what primary care could look like?
Definitely. I think many aspects of primary care could be better supported in providing the resources, the education, the access to the multidisciplinary allied health care in the community. And that would then ultimately support people with chronic pain far better than we do right now. They won't be waiting for a specialist to say, you could have been doing this for a while already. So primary care can get things rolling. There's no waiting. There's potentially, hopefully, more clarity about a diagnosis. However, that is very challenging. But also the person with chronic pain can feel like they're in I like to describe it as a stepped care approach, is that care starts as soon as the person presents to the primary carer and something is commenced. And in collaboration, I heard that really loudly, Kevin, is that there's agency and there's also advocacy and collaboration in that process as much as possible. And also the specialist services also can reach out to the general practitioners to support them and provide specialist input without a patient having to come to the specialty service whilst waiting. So there's that input before specialist services are accessed. So I think there's plenty to do to empower primary care, and then there'll be less wait times for patients then to be seen in the specialist centres, because there may have been some improvement and progress from a primary care approach already.
Yep. So sort of reorganising the deck chairs and the steps, because my sense from experience working in the pain area was that the step that people sometimes waited for was the specialist step, even though there had been multiple other steps before that, because that was kind of like the golden ticket, was waiting for that diagnosis at that point, or confirmation, even though there'd been other steps. So trying to shuffle the steps around.
That's right. It's heartbreaking to see a patient when they've been waiting for 3 years for a diagnosis from a pain specialist when that could have been they could have been supported differently while waiting for a diagnosis, but the diagnosis doesn't mean you can't start pain management and support in many different ways.
Fantastic. All right, you're up, Jen.
Oh.
It's like, it's never coming to me. Look, one of the encouraging themes that's come out of today so far is the willingness to do something. And that there's a momentum around wanting to change the sector and how we can bring along primary care, how we can bring disciplines together, how we can look at evidence, how we can put things in place. And I think one of the other things that we're really hearing is that industry has an important role to play in that. And Hallian has been a great supporter of Chronic Pain Australia and the broader sector around trying to look at the conversations around supporting consumers in their care, and also to Joyce's point around education for existing practitioners around how to better support people. From that point, how do you see Hallion in your kind of role supporting better pain management to ensure that the voices of the people living with pain, like Kevin, are best reflected in the work that you're doing with the sector?
Yeah, it's a,
So you waited, but
I did. I waited.
Totes worth it.
It's a very big question. Look, it's a privilege to represent Haleon here today, sitting on this panel. And in terms of where do we start in our role, I'm really pleased to say that it's with people like Kevin. So we are really passionate as a business and have a deep curiosity around understanding that consumer and that lived experience. So it's really pleasing to me to hear that as passionate as we are about it is as the world of academia is as well, and that those voices are being heard everywhere, because that's ultimately what's going to make the difference, understanding those experiences. So thank you, Kevin, for what you've shared with us today. So as a business, we don't have all the answers, but we do have that curiosity and a deep belief that our role extends far beyond the products that we make and put on shelves for consumers to buy. That responsibility extends to being part of enabling the solution, and we participate in that solution in many different ways. It's in support of organisations like Chronic Pain Australia, and this is our third year partnering the National Pain Report. It's in our support of policy, academics, and driving that education piece that Joyce spoke about really clearly. And that's one of the reasons why we've established the Haleon Pain Management Institute, and we have several esteemed members here today to really work out how we can support academics accelerate their journey of understanding, and how we can all come together and work together to find that solution, because pulling in different directions, we won't. And I think that's been touched on before, the importance of a connected solution. So what I'm really hopeful for is that there are conversations like today that we are labelling a national pain gap, and we as a business are very passionate representing industry and being part of enabling that collective solution.
Fantastic. I think there's a great energy around trying to do that. And I think over the past decade of these kind of information gathering and momentum around pain and chronic pain, you can see that the ball or the snowball is getting bigger and bigger around the tipping point. Nick, I think you're getting your tipping point that you need. Well, I think you are anyway. Moving on to you, Karen. I've got some interesting questions.
Okay.
Ready?
I'm ready.
Ready.
The kids are ready.
Yeah, the kids are ready.
Yeah.
I'm interested in this space myself as somebody who started having chronic pain very young. And I think that when I was reading the report and reading that you're twice as likely to wait to get a diagnosis and the impact that that's going to have on you in the future and the burden that has come with the experiences for people under 25 around, anxiety, depression, other mental health issues, I kind of sit back and I think, I kind of feel lucky to sort of have managed to make it through the other side. Maybe because I had good input from specialists, I had, certain opportunities that, family have been able to provide. But I kind of look at those statistics and I think that impact on kids is significant. And the burden that is then something that they carry through and then have to navigate long term is significant. And so for people who are in at least the survey under 25 and experiencing poor outcomes across education, employment and in mental health, why is recognising it early really important?
Well, I think that's the first thing that stood out to me when I read the report, was really how sad, what a missed opportunity to maximise the potential of our young people in Australia. Like, they're the future generation, and not only are they experiencing, many of them, significant pain in childhood, like they're growing up within that too as well. Like, they're experiencing that pain at a time of critical development, so it can't help but shape their life, experiencing pain at a time of rapid brain, central nervous system, motor skill development, social skill development. It really impacts their ability to engage in life, to engage with school, to learn, to make friends, participate in sport, like build confidence in life, and also fully engage with their family and their community as well. So this is all really important for adulthood, isn't it? And interestingly, of course, you know, if pain is untreated, it doesn't magically end because childhood does. So it has that lifelong impact. So yeah, that was really quite concerning about the report. And what else really stood out to me is not really how early that they're experiencing pain in life, but also how unheard children are as well. Like that's really not okay that children are waiting so long to actually have their pain recognised and treated. It's stopping them from missing out on the important business of being children. And also their families as well. Like when kids can't go to school because of pain, parents can't go to work. You know, they can't engage with their social networks as well, and they've got busy family demands, often siblings who are missing out too, and they're trying to navigate these really complex systems as well, really complex in healthcare, lots of appointments, and actually then just eroding their trust in the system when they can't get those answers, which is really challenging to see that happen. I think it's also really important recognising this early, and I think this is really important that there's inequity in healthcare that really stood out in that report. People who identified with neurodivergence, it took them longer to have their pain recognised and treated. They had more complex pain. And they were also more likely to report that they didn't feel listened to and dismissed by the healthcare service. And I'd actually really I've seen over my years, you know, like that push you probably all have seen, like for trauma-informed care, presume everyone that you come across is going to have trauma. I think we need to do the same for children, particularly if we know that they have neurodivergence as well. As I presume pain is present, ask them, validate their experience, and, you know, give them that opportunity to express that they have pain and get it treated earlier as well. Because every time that we miss that opportunity for early intervention, pain just becomes more complex and more difficult to treat. And the thing that really probably shocked me the most was the impact on well-being. Did you all read that for those respondents who were 18 years or younger when pain started, nearly half of them reported that they had thoughts of taking their own life. Like, that is a wake-up call if any I have seen. Like, you know, it's not just, it really proves it's, you know, chronic pain, it's not just a physical challenge, it's actually a mental health crisis. But I did take the encouraging message from the report that really childhood is our greatest opportunity. If we know that this is where a lot of chronic pain is starting, why aren't we starting there? Why aren't we looking there? We have children who have rapidly developing plastic nervous systems, surrounded by family, supported by schools, primary health care, community settings. You know, it's a great opportunity to make more pain more visible in those settings and help them respond early. Really, when it comes down to it, like, early recognition and intervention is the key. If we do that, we can change the trajectory of these children's lives. All right, I think I'll get off my soapbox.
No, fantastic. You covered all the things I was going to ask you. So
Great.
I'm just crossing them
I'm just
off
waiting
my
for my
list.
opportunity to get on my soapbox.
No, and I think, again, there's so many things in it, but I think the questions around neurodivergence and some of the missed, not unlike adults that might present with depression and anxiety and complexity in other conditions that they might have, and you're unpicking all of those, and it takes a while to get to the underlying other issues that they might have in chronic pain, or how chronic pain may be impacting in those other conditions. And so, like, unpicking the complexity then maybe meaning that missing chronic pain in looking for other things like ADHD or autism or autism-like conditions means that they miss the fact that chronic pain is a key factor of what's happening in people's lives. And I think we saw in the data it was also 1 in 3 broadly in the survey had thoughts of suicidal ideation. So, you know, the broad impact on mental health is significant. So thank you for covering all the points I had on my notes. So, Louise, last but not least, I am going to come back to all of you, so you're not out of the fire yet. Louise, the report highlights the importance of research. I think many people have touched on evidence, they've touched on data, and how that might improve the outcomes for consumers and can improve the outcomes for consumers. Where do you see some of the great opportunities are in research to make a real difference over the next decade? You know, if you're going to talk to the minister, you've got a pitch. You're going to pitch for an MRFF or an NHMRC sort of stream of excellence in chronic pain. What are you going to pitch for the next decade?
So look, I think obviously there's a huge amount of unmet need, as we've heard, and we need better options for people, we need better access, and we have to have research that is driven by consumer priorities and has that consumer involvement at every stage. And so arthritis and musculoskeletal conditions are leading causes of chronic pain, and they have been historically very underfunded in the research space, so getting a fraction of what's going to some of the other leading burden of disease groups. But the government has recently committed to a $100 million medical research future fund mission over the next 10 years, which is an incredible opportunity that we're incredibly excited by. And I think a mission does provide that secure long-term funding, the national collaboration, the opportunity to really properly embed consumer involvement in research and the recognition and the support and the remuneration that needs to go along with that. And I think there's some really good opportunities to look at some key priorities and maybe get some real shifting the dial moments. So things like models of care and looking at how we translate and scale models that we know are effective. So around first line care for conditions like osteoarthritis and back pain, but also around more complex and specialist care. So I think that's a key opportunity. And probably some cross-cutting research around how we do manage pain and how we do support people to stay in work or to return to work.
So many things. A big bucket list, I think, if we had a targeted round for chronic pain, there would be a lot of potential projects that we could... I think it would be a popular pool, that's for sure. And we've got a decade or more worth of work that we could do in the space. Louise, I'm going to start with you and go back in reverse. I want to finish with a final question to the group. If the government could make one change to improve the lives of Australians with chronic pain, what would it be?
So look, for me, I think affordability or lack of affordability of care was the key thing that stood out. When 3/4 of people can't actually afford the care that they need, and we know that they're going to not choose care, they're going to have to pay bills and do other things, and we know that they're going to have worse outcomes and there's going to be a lot of avoidable suffering. So I think the government's done some good things in this space, but would like to see more affordable access to proven models of care that we know work, and probably some things around reforms to the safety net so that people do get a bit more relief from out-of-pocket costs.
Fantastic. Karen?
For me, it would be recognising early intervention for chronic pain as a national priority. And that's just not happening, I know, across the board, but especially with children. Don't quote me on this, but I think maybe we've got 6 tertiary paediatric pain centres in Australia who can maybe see a couple of hundred kids a year. And if we've got 1 in 5 children, up to 30% with chronic pain, those numbers just don't add up for me. And that's going to have to involve taking a look at funding, because it's very hard to get funding for early intervention because it's all invested in our tertiary pain centres. And don't get me wrong, they do an amazing job and I don't want them to lose any funding for that whatsoever, but there's so much that can be done. I'm hearing like in primary healthcare, in building capacity for those community services that are already seeing children on a day-to-day basis, building that capacity in schools, just a lot that could be done there. And also with early intervention, I'll just use this as an opportunity with my soapbox, is also I'd like to see mandating around the experience children have in hospitals with medical procedures, like kids with arthritis, children with cancer I work with, cardiac kids, they all need a lot of procedures. And I've seen a lot of them traumatised, and I've seen a lot of traumatised adults too. So I'd like to see early intervention with mandating around zero tolerance of procedural restraint in hospitals.
Joyce?
I think from a government viewpoint, access is critical because, and that goes along with early intervention. I think they dovetail because when you have one, it solves the other. And access is critical. Access from the ability to have relief from the doctor's point of view, so supporting doctors to enable access. Access is a really big word. It's like, what do you mean by access? It's come from all the components, and that requires the ease of that line of where to go to. And I'm having done a lot of work in primary care, I'm an avid, obviously, that's the release valve, the easy, quick release valve. And while we have education, stepping up and all that kind of things, but even if there was one thing that could allow that access to free up, that's at that point would solve your early intervention issues. It would solve stigma and invalidation issues for starters. And so I think all the things that wrap around that access is critical. And that's where cost escalation comes about. Because of no access, then you got to do your round and your round and round again. So I think that's number one. The other thing is, I think, other than the government, I think we all have to keep rattling this cage. Thank you so much for industry, to philanthropy, whom I've had the privilege of working closely with over the last, sort of year now, actually. The community, all of us, I think and that data piece. So we got to play our part there, got to keep making the noise, educating the government in making that decision. So I think the access is really important, but I think it comes back also to go, we don't want to just go, you got to solve the problem, government. Us, what can we all do? And I know we all are here doing that and more. And this is so critical that all of community solves this problem, because the trajectory, WHO has predicted the trajectory is phenomenal. It is phenomenal. And this is for generations ahead. So I think this is where that impact will come in.
What's really clear from the conversation today and this incredible report is how vast the problem is, and its challenges in terms of visibility. So I want to circle back to what Nicolette said at the very start about the importance of measurement and government-funded measurement, because we are here today talking about insights that have come from a community group-funded study, and how lucky are we to have a group such as Chronic Pain Australia that can provide that kind of information to groups such as this. I would definitely say we need to be measuring it, we need to understand it, we need to bring it out of shadows. I was startled talking to Kevin before the panel of just how much he contributes to society, and I wonder how many children there are that can have a future life like Kevin if this is solved for them. So let's start bringing it out of the shadows, and I think measurement is a really key part of that.
Yep, I definitely echo the measurement. I think in particular for the government to focus on chronic pain as a health condition in its own right, that it be equally recognised as a condition that needs to be measured, but also particularly measured in a way that informs the resources that are required, the model of care that is required, the actual outcomes that matter to people with chronic pain as well. So there's numbers that we can count, but it's so much more effective if you can understand the qualitative outcomes. What makes a difference to people living with pain? Not just we've seen them, but actually has it been effective? Has it been a priority of theirs to pursue a particular way of managing their pain? What do we know then that is incredibly effective and valuable to the person with chronic pain?
Which ends perfectly with what Kevin thinks.
Thank you for asking all the right questions, and I've just made a few notes on my little pad here, and what I've heard over the last half an hour or more, there's so many things I could finish with and ask the government about, but I've just written here, diagnosis is important, education important, fragmented care, stigma, and that's what I want to talk about in particular. I haven't got on my soapbox yet, and I've got the last say. So for me, as an invisible illness in many cases, chronic pain does have a stigma, and it's been mentioned a couple of times about the World Health Organization, or particularly about categorising pain. Now, I'm aware that the World Health Organization has recently recognised chronic pain as a disease process in its own right, and it was just mentioned that we need to measure that, and the only way we can measure that is in Australia by our government having those statistics. It's been mentioned a couple of times earlier on by Nicolette as well. We don't know, we can't get those resources unless we know exactly how many people have chronic pain, and you can't see that by looking at people walking along the street. I often get asked, "Oh, you look fine, what's wrong with you?" You can't see it in many cases. It's on the inside. And the mental health aspect is extremely important, and I was very struck by the plight of children. We have a niece who's actually got complex pain, and she's so young, in her early 20s. I mean, I had a bit of life experience behind me, 51 years before I got chronic pain, and I can only imagine, I can't put myself in the shoes of a child, but my heart goes out to those parents and children who've got their whole life in front of them and need that diagnosis early in life. Now, I want to finish with one thing which is my particular soapbox, and I wanted to talk to people or mention to people to think about when you're diagnosing chronic pain, and you could be a health professional, a physio, a doctor, a specialist, the diagnosis is so important. And that's what I wanted to finish on. I wasn't diagnosed for 7 years, and the early treatment that I could have had, which may not have produced the eventual response into chronic pain, was missing. There were no multidisciplinary care specialists 17 years ago, unless you travelled a vast distance and paid a lot of money and you saw the specialist, but there was no allied health team with them. So that's what I wanted to finish on. Diagnosis. Doctors need to be trained. I know diagnosis is difficult, but I wanted to know, and I've learnt since, that my pain is chronic secondary pain. I have a physical condition that causes my pain, but for years I was told, oh, you just need to do a little bit more P&E. What's P&E? Pain neuroscience education. Yes, I've already done that. I've had chronic pain for a long time. I don't suffer from psychological issues. I have a physical deteriorating degenerative illness, and a lot of people, I believe, need to find that out a lot sooner in their treatment plan so that they can address that physical injury. Sure, psychology helps, sure, pain research therapy helps, treatment helps, but we need to classify and find out what people are going to benefit from most. A psychological approach or a physical approach, which often needs pharmaceutical help. And that's what I'll finish with. Make sure your patients have a fully multimodal, holistic, multidisciplinary care. Believe what they say. Listen to what they say. I can't say it any better than that. Thank you very much.
I think that's a really good way to finish this part of the panel, because pain is what the patient says it is. Which is right. It is. It's what you say it is, because your pain and my pain are different, but they're still pain, and it's how we're experiencing it. So what we've heard from the panel today are some really important points. We've heard about access, affordability, agency and advocacy. We've heard about partnerships with people with lived experience, with practitioners, with the education providers, with industry, with researchers. We've heard about empowerment, empowering providers, empowering consumers, empowering the system to be better. And we've heard about opportunity. We've heard about the opportunity to look at data, to look at evidence, to look at areas like childhood pain, to try and stop it before it starts, to try and intervene early with research, to look at priorities around things like models of care, and to think about chronic pain as a health condition and how we can do better. So I'd like to thank everybody on the panel. Thank you for your insights. Thank you for your humour and putting up with my questions. But today's discussion has really reinforced the importance of improving pain care and what is required as a group action across the entire system. I mean, it's pretty clear that we've all got to work together. From earlier recognition right through to better education, to multidisciplinary care, consumer-led research, and stronger national leadership. And what we've got is very clear leadership. We've got national leadership, but we need to continue to drive that. Most importantly, what we've heard is why chronic pain must become visible and not invisible in Australia's health data, so that people living with pain are recognised, counted, and supported. Thank you to all our panellists. I'd like you to put your hands together one more time for our panellists today. Thank you to everybody, and I know there's probably people in the room here today that contributed to the pain report and to the survey individually, so your data counts as well. And thank you for joining us all here today. Please support the Make Pain Counts campaign that Nicolette spoke about at the beginning of today, and help us ensure that chronic pain is counted in Australia. But even more importantly this afternoon, enjoy us for afternoon tea, which will follow afterwards. Meet some new people, talk about how we can move forward with this in the future. And thank you for your attendance today. Thanks very much.